Hello, dear friends. On behalf of International Society of Pediatric Oncology, SIOP Education and Training Committee, and International Pediatric Association, we warmly welcome you to first webinar of SIOP Childhood Cancer Early Diagnosis and Appropriate Referral CEDAR project. I am Dr. Mohammad Saghir Khan from Pakistan, Chair of SIOP Education and Training Committee, along with my fellow co-moderators, Dr. Claudia Sampor from Argentina, a very active member of SIOP Education and Training Committee and SIOP Latin America, and Dr. Mychelle Farmer from USA, who is very insightful about this CEDAR project. She is co-chair of IPA Strategic Alliance Group on NCD. So what about the rationale of this project? As you know, survival outcomes for children with cancer are quite lower in low and middle income countries, where nearly 90% of the children with cancer reside. Diagnostic delay in childhood cancer is a significant problem in LMICs, which leads to high rates of advanced disease at presentation. Delayed diagnosis, underdiagnosis, and particularly no diagnosis are estimated to be like 50% of the cases. And the main reasons are lack of early recognition of symptoms and signs of childhood cancer among healthcare providers, and barrier to access for prompt consultations and referrals to higher levels of care. So SIOP CEDAR project, in collaboration with IPA, is launched to improve the knowledge and understanding of general healthcare providers, including pediatricians, family practitioners, and community nurses involved in the initial care of the pediatric patients suspected of having cancer. So we would offer practical advice from oncology experts from all around the globe for better knowledge to identify children with suspicion of cancer at earliest possible stages. In our first phase of CEDAR project, we will be focusing on 6 WHO index cancers, which include acute lymphoblastic leukemia, Hodgkin's lymphoma, Burkitt's lymphoma, Wilms tumor, retinoblastoma, and low-grade glioma. So this is Gold September, Childhood Cancer Awareness Month. So we are launching this CME accredited webinars and with free registration, with first session today, and then it will follow with 6 more sessions on monthly basis from October till March on WHO index cancers. You can retrieve further information on the link given at the bottom of the slide. So some housekeeping instructions. We have 4 presentations from 5 highly esteemed professionals, speakers. That will be followed by question and answers. So please feel free to write the question and answers in the tab below, and we will take the questions in the dedicated session. So we are offering simultaneous Spanish translation. So those folks who want to listen the Spanish, they can click on the bottom of the screen with a globe and select Spanish language. So this webinar is accredited with CME, which will be shared with you after the session. So we have 5 esteemed speakers. Professor Kathy Pritchard-Jones, who is the president of International Society of Pediatric Oncology and professor of pediatric oncology at University College London, Great Ormond Street Institute of Child Health. And she's been involved in so many clinical and translation research in childhood kidney cancers. She's medical director for an integrated cancer system of healthcare providers. The second speaker is Dr. Liliana Vasquez. Dr. Vasquez is president of Latin American Society of Pediatric Oncology, SIOP, and continental president of SIOP Latin America. She is international childhood cancer consultant at PAHO and WHO, and Master of Medical Research, Clinical Research, and Global Health. Dr. Eddie Supriyadi is a pediatrician and a pediatric hematology oncologist from Indonesia. and is a very active member of International Pediatric Association, Indonesian Pediatric Hematology Oncology Working Group, ACCA, St. Jude Global Alliance, and SIOP. We are honored to have Dr. Andre Ilbawi, who is the lead of WHO Cancer Program at WHO headquarters at Geneva. And he is the key power behind implementation of the 2017 World Health Assembly Resolution on Cancer Prevention and Control, and the man behind WHO Global Initiative for Childhood Cancer, which was launched in 2018. And it is now being implemented in over 60 countries. Is executive editor of 2020 WHO report on cancer and key contributor to additional WHO publications on broad topics ranging from guidance on cancer prevention to access to care health products. He's also playing his vital role in WHO IARC priorities setting tool, workforce optimizing strategies. And last, we have Dr. Roberta Ortiz, who's a medical officer for WHO Global Initiative for Childhood Cancer, pediatric oncologist from Nicaragua. And she had lots and lots of collaborative pediatric oncology engagements over the last 1 decade in Latin America and now at the global level. So let me invite our first speaker. And it's really my honor to request Professor Kathy Pritchard-Jones to start with the first presentation. She is president of SIOP, International Society of Pediatric Oncology, very innovative and dedicated person and a dynamic leader. So she is the person behind this evolution and this webinar series as well, CEDAR projects. So Kathy, floor is yours.
Thank you very much, Saghir, for that kind introduction, and welcome to everyone who's joining online. This is a really important partnership between the International Society of the Healthcare Professionals who look after children with cancer once they've been diagnosed, with the International Pediatric Association, which reaches out to all those involved in more general healthcare for children around the world. And I think this partnership is absolutely critical if we're going to improve early diagnosis and rapid access to appropriate diagnosis and treatment pathways for children with cancer around the world. So I have been asked to talk about what's missing in low and middle income countries. Of course, things are not missing completely, but there are relative deficits, and sometimes things have to be done in different or adaptive ways. So I want to cover some of these points, and they'll also be emphasized or covered in much more detail by some of the subsequent speakers. But I think one of the key things that is missing in many countries, and never mind their income status, is public and political awareness of childhood cancer, that it exists, that it's curable, and that children can be long-term survivors and be back in society and get value from their lives. We also know that cancer registration is very incomplete or often just not there in low and middle income countries. And both of these things lead to us having incomplete knowledge of the cancer burden in children and young people, and being able to ensure early and accurate diagnosis. Once children are diagnosed, of course, there is a need for rapid access to appropriate treatment with supportive care. So things like blood products and so on can be a challenge. There's a lack of the necessary multidisciplinary trained workforce, both for diagnosis and care. And all of this leads to suboptimal survival chances at the moment. And then, of course, family support and information, which is essential to have families and patients as partners in their own care. So back to the public and political awareness. Childhood cancer is biologically very different from adult cancers, and many doctors and nurses do not know that if they're not in our specialty, never mind the general public or your political and healthcare leaders. So this is an important message, that you can't apply early diagnosis and screening techniques developed for older adults who largely have carcinomas that are hard to treat in an advanced stage and have relationships with environmental agents. And in children, we see, and these are high-income country proportions, a high proportion of childhood cancer is blood cancers, about a quarter are brain tumours. We then have this very special category of what are called embryonal tumours, representing cancer in children being development gone wrong, and then the bone, sarcoma, and the other 12 cancer types. And what you'll see is as children age into adolescence and young adults, that spectrum changes, and beyond 30, we start to see the more typical adult patterns. Now, it's very important when we recognise and diagnose cancer in children and young people that we're all counting the same thing. And that's why there is a specific international classification for childhood cancer, which is led and developed by the International Agency for Research in Cancer in IARC. And they are also running a cancer registry improvement scheme globally at the moment. Where cancer registration is complete and in a high-income country setting, we know that cancer affects about 1 in 430 children by the age of 15 and about 1 in 320 by the time they're 20 years of age. But nearly 50% of childhood cancer occurs before the age of 5. So this is preschool children, many of whom are on regular child surveillance programs, child health checks in high-income countries. Now, depending on where you live and the age structure of the population in your country, childhood cancer is somewhere between 0.5%, so that's only 1 in every 200 cancer cases in the country, to nearly 6%, which is over 1 in 20 in some parts of sub-Saharan Africa. But we do know that, and this just emphasizes the point, the map of the world with the red areas being the deficits, this is where there are no cancer registries at all. The yellow countries have some regional population-based cancer registration, and the green countries have nearly complete coverage. So what you see is that North America and Europe are pretty complete, as is Oceania, but in Asia, Latin America, Africa, a very small proportion of children with cancer are actually monitored by cancer registration. So it's highly likely that even with the numbers we know about now, they're a gross underestimate of the true burden. But what we also know is that more than 90% of the world's children live in low and middle income countries. And if they have cancer at the same rate as we see in high income countries, this is an estimate of the incidence deficit of childhood cancer. So it looks very similar to that map you saw. Africa is probably the continent where there's the largest number of missing cases, but also large parts of Asia. And between Africa and Asia, they cover about 2/3 of the world's children. So this is a large number of children who need to be recognized and to have help to have their cancers diagnosed earlier if it does develop in them. Again, this column here shows a graph of how these estimates have been derived. And you can see that it's estimated in high-income countries, maybe only about 3% of childhood cancers go undiagnosed. And that's up to nearly 50% in Africa and some parts of Asia. So what can we do about this? Well, this is why we have the Global Initiative for Childhood Cancer. And it's focused on these 6 cancer types, which are prevalent in all countries around the world. Together, they make up about half or slightly more of all childhood cancers. In a high-income country setting with full services and access to drugs, they are highly curable with proven therapies. And the earlier they are diagnosed, in other words, the less advanced the disease is at diagnosis, the more likely you are to be able to achieve more than 90% cure rates with treatments that are unlikely to give any long-lasting side effects. So this is why these have been chosen to focus on, and also getting it right for each one of these cancer types involves some different aspects of organisation of healthcare services and workforce. But what we do know is that where it's been tried successfully to bring together the multidisciplinary teams and the therapeutics you need to diagnose and treat these children, it has a halo beneficial effect on general pediatric services. So everybody benefits. The children with cancer benefit from being diagnosed earlier, having a chance to live. The healthcare teams looking after them benefit because they have positive successes. And then the hospital within which they provide their diagnostic and treatment services also benefit from the expertise that is developed in recognizing these serious illnesses earlier. But here's where we are now. These are the estimated 5-year survival rates for cases diagnosed in 2015. And again, I emphasize these are estimates because due to the lack of cancer registration in Africa and large parts of Asia, we don't know for sure. But what we do know is that in high-income countries in North America and Europe, 5-year survival across the board is well over 75% now, and it's much higher in certain cancer types or early stage disease, and down to less than 20% probably in some parts of the world where services are missing and children are being diagnosed too late. Now, the Global Initiative for Cancer Registry Development, which is led from IARC in Lyon, France, has put in some investment and skills into supporting the existing cancer registration services in some low-income countries. And here you can see the data from 3 population-based cancer registrations in 3 regions of sub-Saharan Africa: Abidjan in Côte d'Ivoire, Harare in Zimbabwe, and Kampala in Uganda. And what I'd like you to note here is that they've been able to apply an international standard of measuring tumor stage at diagnosis to these cases. So you can see here for Wilms tumor, which is the commonest type of kidney cancer in children. It really is a disease of children under the age of 5 in the main, that if you can catch it early, so localized disease, that they're already at a 60% survival rate, which is the target in the first instance of the global initiative. But you'll see the much more dismal survival chances if children present with metastatic disease at diagnosis. But even then, some of the children can be long-term survivors. So why is this? Many low and middle income countries start with a disadvantage. The cancer is diagnosed at a very advanced stage. And so the chance of cure, even if you were in a high income country with all therapies at your disposal, would be much less. And here you can see in these 4 common cancer types that the proportion that already have advanced or metastatic disease at diagnosis is about half the children or more. And this is something we can do something about. We can shift if we can recognize children earlier as possibly having cancer and getting them referred to places where it could be ruled out or confirmed, and then treatment started rapidly. And so this problem also reflects in what you see here. There's slower improvement in mortality rates in low and middle income countries. This is death rates now, so you expect them to come down, and you can see on the left, this is Australia and the United States, that mortality rates now are very low in more recent decades, whereas in some other countries like Azerbaijan and even Brazil, mortality rates don't seem to be shifting. But we can do something about this, and the WHO Global Initiative for Childhood Cancer, working with clinical and healthcare experts around the world, is producing some really excellent technical and policy documents that will support healthcare services and the healthcare professionals to improve what they can offer their population. So the causes of treatment failure are well understood and they are tractable. So it's possible to do something about them. Sorry, I'm gone too fast. And if we take the cancer like Burkitt's lymphoma, which is one of the commoner cancers to present in sub-Saharan Africa, possibly because the classical Burkitt's comes as a jaw tumor, so you can't really miss it, a child with a hugely swollen face. But many of them still are not diagnosed, or the diagnosis is not correct, or the family can't even afford to start treatment, or they start treatment but can't afford to keep going. There is a small proportion of children that will die of the toxicity of treatment. And again, that can be due to inexperience of the healthcare team or lack of access to the appropriate supportive care, drugs and blood products and antibiotics and so on. And of course, whatever you do, some children will relapse, but some can be cured. And if you look at the graph on the right, you'll see the relative proportion of these causes of why a childhood cancer treatment fails, according to the income status of the country. And then in the low-income countries, there's a lot more children not diagnosed and less ability to give curative treatment. And that's mainly because the children are coming with very advanced disease, as I showed you on the previous slide. But where specific initiatives can be inputted, a lot of work's been done to help children with Burkitt's lymphoma have curative treatment, even in countries with as few resources as Malawi. It's possible to really improve the survival chances and reduce abandonment rates by making the treatments much shorter and still effective. This is another example of a solid tumor where the treatment's more complicated than lymphoma. Lymphoma can often be cured with chemotherapy alone, whereas Wilms tumor requires at least a surgeon and sometimes a radiotherapist. But again, with focused interventions and a team approach, you can reduce abandonment, you can halve it. Here you'll see in this African project from 23 to 12%. And you can reduce the toxic death rate during treatment, and they already got to 50% survival at the end of a 2-year assessment period. So we know how to do this, but we can really help the local teams be more successful, help the children with cancer if we can achieve early diagnosis and rapid and appropriate referral to the right services. So I'm really pleased that we're able to launch this webinar series, and so many of you have signed up and joined us. And we look forward to hearing from the next speakers and having a good discussion at the end. So thank you very much for listening.
Thank you very much, Dr. Kathy Pritchard-Jones, for your excellent presentation. So let me introduce now Dr. Liliana Vasquez. She's the current president of the Latin American Pediatric Society of Pediatric Oncology, the SLAOP, and the continental president for SIOP for Latin America. Welcome, Liliana.
Thank you so much. Thank you so much, Kathy, for this nice talk. And thank you so much, Claudia, for the presentation. So I'm really happy to be here and share with you some thoughts about early diagnosis of childhood cancer and the role of healthcare providers and organizations. And I'm really honored to be part of this first webinar of the SIOP CEDAR project, which I think is very exciting. So some first thoughts about why I think it's important that we're here, why it's important to have this series of early diagnosis in childhood cancer, why childhood cancer is important. And I think that it's because even today, many of us still hear from our colleagues, from families, from people, policymakers, also that childhood cancer means death, that childhood cancer are rare diseases, that to treat a childhood cancer is expensive. So this is definitely not true. And I wanted to start this presentation with some data about this, because I believe that this is really important. Childhood cancer doesn't mean death. And I think Kathy has very beautifully commented that many progresses are doing in several countries, in high-income countries. And the progress that we're seeing during the last 50, 60 years, probably that as she's just shown in Australia or other high-income countries in Europe, in North America or in Canada, definitely are not the same for all of us. And that some low-income countries does not have the same results. So this is known as the pediatric cancer survival gap. This is something that definitely is not getting better, right? We're not getting better at this, and probably we do need to do more about this. Secondly, that childhood cancer are not rare diseases. And we know that each year around 400,000 children will develop cancer globally. And this is an important number. It's one child every 80 seconds. And sadly, most of these children will live, 90% of these children will live and be treated in a low middle income country. And where we're seeing that the results, the survival is not that good as we expected. And finally, that to treat a child with cancer is not expensive. And this is some important evidence that we just that we know from a very important report from the Lancet Oncology Commission that was published in 2020, and that we have now the very robust evidence that for $1 that we invest in the treatment of the child with cancer, we can get at least $3 of productivity. So 3 times of what we are investing will, and we start investing now in these children and adults with cancer, we will prevent at least 6 million deaths in the next 30 years. So this is some important data that we should consider when we start reflecting why we are here, why we need to do more for these children around the globe. And also why early diagnosis of childhood cancer is important, of course, because I would start by saying that it's not only important to address early diagnosis of childhood cancer. And again, based on this very important evidence of the Lancet Commission in cancer that was published, is that one strategic strategy is not enough. We need to do better. For example, to start investing in early diagnosis, in abandonment of treatment, in the supportive care, all of these strategies, all of these interventions that we could do together will make a difference, but not only one intervention. And this is actually what is based the Cural Framework and the Global Initiative for Childhood Cancer that will be later be presented by Roberta, because this framework, this Cural Framework, is really a comprehensive alternative and strategy to improve the care in a timely manner and with quality. And also because something that already Saghir was mentioning at the beginning, that probably half of all the children will never get diagnosed. And of course, if we did not invest now in interventions for early diagnosis, probably we will still be seeing children with huge tumors, large tumors, big eyes of retinoblastoma that probably many of us have seen at least once. And or sadly, the most difficult situation that these children will never get diagnosed. And this is something that we need to address now, of course, because probably the early diagnosis, and I will explain this in the next few minutes, are several good interventions that have been proven to make some impact in the prognosis of these children. And what does the evidence says today that it's relevant to invest time and money? And unlike the situation that we see in the adult oncology, the systematic screening for childhood cancer does not have had the best results or the best impact that we have that we would like to be. And interventions, for example, in neuroblastoma or other certain types of childhood cancer have not have good results. So definitely the development of targeted programs that promote the early identification of symptoms and signs are the best option and have demonstrated some good results. And some examples that I'm showing you here are from Latin America, but of course there are many other around the world. But in Latin America, for example, we have had this experience in several countries with good programs in retinoblastoma, for example, in Honduras, with good educational interventions in Argentina, in Brazil, in Peru, where we had the experience of using a mobile application for early diagnosis, Oncopeds, in Central America, in Paraguay, with the programs of Mychelle Matters. Many of these interventions have been very impactful in the countries and have demonstrated to decrease the possibility of having a late diagnosis, a late stage of disease, or to improve the outcomes and reduce the mortality in these children. And this is included in regional snapshot that we just published at PAHO. And if you want to know more, you have the QR here. But what can we do as healthcare providers, as organizations? This is a good question because we can always do more and we need to do better. First, we need to share and develop, if you want to develop some materials, of course, related to early diagnosis of childhood cancer. There are many available already in English, in Spanish, in French, in Creole. I've prepared some links for you as well that at the end I would like to share, because indeed, there are several good materials that we can find in the web from SIOP, from YCC, from different organizations that we can use, we can share. And if you would like to develop some new campaigns, you can not reinvent the wheel. You can start from something that is already produced. Also, something that is important is that we can, and we should learn more as pediatricians, as part of the multidisciplinary team treating children. We need to do more in the learning and the education of childhood cancer. And I'm showing also here some information about the virtual course of PAHO and WHO about early diagnosis of childhood cancer, because there are several others types of training, but this is a good resource that has been recently launched in Spanish, in English, and Portuguese. And I totally encourage you to learn more about this topic, about the early diagnosis of childhood cancer. And finally, to advocate, because we need to do better also about the percentage of countries that have an early detection program or guideline, specifically for childhood cancer, but at least in general for cancer that could include the pediatric component, right? Only 20% of countries around the globe have already an early detection program or guideline related to cancer or childhood cancer. And this is really low. And we need to do better at motivating the authorities, motivating the policymakers, the governments to increase the number, decrease the possibility to have these programs or guidelines or regulations that includes some operational activities for early diagnosis of childhood cancer. So some take-home messages that I would like to share with you. First, and most importantly, do not miss the CEDAR training sessions because they're very interesting, and you need to encourage more people to attend during the following weeks to learn more. First of all, that it's very easy, it's very powerful. You can save a life by learning more about childhood cancer, to advocate for children with cancer they want to live. And finally, to share and develop these materials, because we do not need to reinvent the wheel. We need to build on that. And of course, improve. If you would like to improve some materials or adapt it for your settings, that's also very valuable and very important to do. So thank you so much for the invitation, and happy to be in the discussion.
Great. Thank you. Thank you so much, Dr. Liliana. That was really a wonderful presentation. Our next speaker will be Dr. Eddie Supriyadi. He is a pediatrician and pediatric oncologist from Indonesia and an active member of the International Pediatric Association. So very happy to have Dr. Supriyadi join us, and he will be our next speaker. Welcome, Dr. Eddy.
Thank you very much, Dr. Mychelle, for introducing me. And thank you very much for audiences for joining in this webinar. I'm really very happy to be here to present the idea to improve the index of suspicion in childhood cancer. And I was inspired by this picture. It happened in West Java in Indonesia 10 years ago. The students were struggling to go to school because the wire or hanging bridge was broken due to the flood. And similarly, the children here and other LMIC struggle the best manage their diseases, especially cancers. starting from early finding, diagnosis, as well as treatment. I think that a relatively high incidence of childhood cancer, but not become a health priority in the country. And talking about the fact of the children with cancer, it was already mentioned that 400,000 new cases per year and more than 80% living in developing countries with its problem. And then questions arose. Could cancer be prevented? No. And we can screen the some of the cancer, like in the children cancer, in the childhood cancer, the retinoblastoma can be screened in some high-income countries. Many of them were found accidentally. Parents brought the children to the high care because to the healthcare provider because other symptoms. And an increasing of mortality caused by delayed diagnosis as well as misdiagnosis. And as Kathy has already mentioned, that poor registry has also happened in this low and middle income countries. So WHO stated that children with cancer as a priority in the country, especially in the low and middle income countries. Another fact of the children, that 80% of the children with cancer will survive in a high income countries, but only 20% of the children with cancer will survive in some low and middle income countries. And why only 20% will be survived? Many factors, many contributors. One of them is prolonged delay. The prolonged delay comes with a parent's delay of the low education because of low economy with some various of geography, and some of parents here, especially in low middle income countries, took the alternative medicine as the first choice of the treatment. And also the primary health care play important roles for the delay of the diagnosis because the lack of acknowledgement about the cancer in children. And also the health system also play a role in the prolonged delay of diagnosis. In a study conducted by college in West Java, Indonesia, it was found that delay in childhood cancer was happen in a primary healthcare and secondary hospital and tertiary hospital, starting from the first symptom that should be known or identified by the parents to the first contact with the healthcare provider is called the parent's delay. And from the first healthcare provider to the early recognitions by the oncologist is the referral delay. And some professional delay or onco delay starting from early and recognition by oncologists to the diagnosis making. And from the diagnosis making to the treatment is treatment delay. All have play a role and contribute in the daily diagnosis of the cancers. So as I mentioned from the speakers before, the WHO have a global initiative. The goal of global initiative is to achieve at least at 60% of survival and to reduce suffering for all children with cancer by 2030. And 1 million children cancer can be saved on the next decade. And then how to achieve? Of course, with collaboration from public elements and stakeholders, including non-governmental organizations, we can achieve this goal. How? First is an early diagnosis. And early diagnosis, and this one requires a high index of suspicion from the parents, from the primary healthcare provider, secondary, as well as tertiary healthcare provider. They have to be having a high index of suspicion, and also how to recognize the high-risk group, as well as the recognizing the red flag signs of the childhood cancer. But then questions also arose that is this a real red flag signs in the childhood cancers? Then we can discuss later. And about the high index of suspicious, in general practice, cancers are rare. So be aware of the abnormalities that found in the blood and bone marrow, like pancytopenia with all clinical manifestation, and the brain and the bone and the lymph nodes and the abdominal tumors and the soft tissues. And we have a mnemonic of the child cancer. Child, a C for continued unexplained weight loss, and H for headache with or without vomiting. I for increased swelling or persistent pain in joint, in legs, in back. And there's a L for lump or mass in abdomen, head, neck, chest, and pelvis. And development of excessive bruising, rash, or bleeding, the manifestation of low platelet. And cancer, C stands for constant infections, a patient with prolonged fever, and A for white eye or a whitish color behind pupil, N for nausea with or without vomiting, and C for constant tiredness, E for eye or vision changes suddenly or persist, and R is recurrent persistent of fever of unknown origin. So what to do if we found suspect or diagnosis malignancies? Of course, we have to refer, but who should you refer? The children with suspected malignancy, but whom do you refer to? Of course, to the pediatric oncologist, but some cities do not have the pediatric oncologist. And what should you do before referral? First, you have to discuss with the pediatric oncologist, with a text, with a telephone, with some many communication. And important, avoid direct referral to surgical disciplines. And also, the last thing, avoid invasive procedures. So the role of non-government organization is also important. We have many non-government organizations. One's called Yayasan Anyo Indonesia, who has already made an education in the 33 of 34 provinces. And they have made the collaboration with local policymakers in terms of medical personnel, information exchange, and they made and distribute the guidebook of early detection of cancer in children. And this non-governmental organization have focused in retinoblastoma. They have an education as well as a training, and then providing the ophthalmoscope and also training. And they have a specific program called 1,000 ophthalmoscope movement, and distributed to the 1,000 primary healthcare for the early detection of retinoblastoma, because they have a motto like save eye, save life, and save money. I think this is the importance of the non-governmental organization in terms of making the high index of suspicion. Thank you very much.
Thank you so much, Dr. Eddy. That was a wonderful presentation. You covered so much information that is helping us to improve our strategies for early diagnosis. For all the participants, we have one more presentation, and we would ask that you put your questions in the Q&A box, because the presenters and the panelists will be able to answer them during the presentations, but also they'll be able to answer them during our brief discussion session. Thank you. Our final presentation will be a joint presentation by two great leaders from the World Health Organization, Dr. Andre Ilbawi, who is the lead for the WHO Cancer Program and also initiated the Global Initiative for Cancer Care, and Dr. Roberta Ortiz, who is the medical officer for the Global Initiative for Childhood Cancer. And the floor is yours, Dr. Ilbawi and Dr. Ortiz. Thank you.
Thank you so much. I will get the presentation started. I wanted to know if I'm able, yes, I see I'm able to share my slides. Thank you very much. Okay, just let me put them in presentation mode. There we go. Thank you so much. So once again, good morning, good afternoon, and good evening to all. I want to thank SIOP Childhood Cancer Early Diagnosis and Appropriate Referral Project organizers for inviting WHO representation to this important event. We are very grateful for SIOP for their work strengthening our joint program of work that is contributing to the World Health Organization 13 General Program of Work and the triple billion targets. I'm sorry, I think we have some. Okay, here we go. There we go. So we are all aware that cancer represents a major public health issue. I'm having some issues with the slides here. Here we go. And that nearly 20 million people each year are diagnosed with cancer, and cancer is responsible for 1 in 6 global deaths. With the support of the UN agencies, IAEA, IARC, and over the 300 committed partners, WHO in its 3 levels is providing active committed support to member states in formulating comprehensive responses to the growing cancer burden. Through the WHO, through the World Health Assembly Resolution 7012, Cancer Prevention and Control in the context of an integrated approach, WHO received the mandate to support member states to prioritize the cancer agenda and lead the global cancer response. To deliver on this mandate, the 3 cancer initiatives were launched: the Cervical Cancer Elimination Strategy and the Global Initiative for Childhood Cancer in 2018, and most recently, the Global Breast Cancer Initiative during World Cancer Day this year. Through the development of standards and tools, the World Health Organization is supporting countries in the planning and implementation of interventions for the prevention, early diagnosis, screening, treatment, and palliative and survivorship care for both adult and child cancers. As has been mentioned before, childhood cancer constitutes a significant and relevant public health challenge. Burden of disease is heavy and access to care is uneven. The factors responsible for the inferior survival affecting children with cancer in low and middle income countries has been very well described by my previous predecessors, Dr. Pritchard-Jones and also Dr. Eddy. All of us here know that the progress in childhood cancer control is feasible with small strategic investments to improve the quality of care, as Liliana has told us. All of us can assure that childhood cancer is a highly curable disease when diagnosis is prompt and adequate, when children have access to adequate disease-specific treatment and supportive care. Advancing to childhood cancer control represents a starting point in the fight against non-communicable diseases, contributing to achieve SDG targets, particularly 3.4 in the reduction of premature mortality from NCD through prevention and treatment, and target 3.8 towards achieving universal health coverage. So recognizing the need for action, the World Health Organization, alongside St. Jude Children's Research Hospital and global partners, launched the Global Initiative for Childhood Cancer at the United Nations General Assembly during the third high-level meeting on non-communicable diseases in September 2018, setting the global target that we all know of increasing global survival for children with cancer to at least 60% by the year 2030, while reducing suffering for all. WHO, with the support of all their partners, remains committed working to achieve this goal by increasing countries' capacities to provide quality services for children with cancer and increasing the prioritization of childhood cancer at global, regional, and national levels. On the road to achieve this ambitious target, currently 62 countries in the WHO regions are implementing the Global Initiative for Childhood Cancer operational approach, which is known as the Cural Framework, which is based on 4 pillars and 3 enablers represented by the Cural acronym. The Cural Framework is intended to guide policymakers and program managers by outlining key interventions needed to scale up the capacity to provide quality services for children with cancer and contribute to the formulation of their national policies and plans to advance implementation and monitor for improvement. You can see here listed in the right the list of the 10 Cural priority projects or priority interventions that will support the implementation of the initiative in different countries and in different contexts and settings. The implementation of the Cural pillars and enablers requires 4 coordinated steps or 4 phases of country action. Initial assessment phase, where a snapshot of the current country state of childhood cancer services is performed by an analysis, a situational analysis of both national and facility levels. Planning and costing for implementation will be the second phase that is conducted through a multi-stakeholder mapping and engaging approach to mobilize resources required to implement the prioritized activities that the country has selected from the list that I've shown you before. The implementation phase itself will be achieved through effective collaboration among multiple sectors, including the government, health facilities, professional organizations, parents, patient support groups, non-governmental organizations, all mobilizing resources across different sectors to support the government efforts to accelerate progress, which has been the key in the success of in the countries that are now actively engaging in the implementation of the Global Initiative for Childhood Cancer, as you will see with further examples. And finally, to monitor and to modify for improvement, countries will select a group of outcome measures for indicators in line with the strategic plan for action to identify program needs, focusing on quality improvement and in research priorities. As part of the Cural technical package and its suites of tools that we have developed in WHO, we are currently developing a monitoring and evaluation framework with a list of proposed indicators that I will share with you in just a moment. Complying with the World Health Organization core functions that guide in-country cooperation and in alignment with each country cooperation strategy, WHO, through the implementation of the 3 cancer initiatives, is providing support by strengthening its leadership function to promote partner networks, catalyzing funds, monitor for impact, but also promoting innovation and shaping the research agenda. Promoting strategic policy dialogues, setting norms and standards, articulating ethical and evidence-based policy options to promote health system strengthening, and by providing effective technical cooperation to support catalyzing change and prompting capacity building. Here are some of the examples of country support which evidence the progress achieved in the implementation of the Cural approach at country and regional levels. Excellent examples of prioritization of childhood cancer international policies and programs such as the Philippines, Peru, and Ghana, where the inclusion of the 6 index cancers has been able to be achieved in the national essential service packages. Also, contribution to the improvements of quality service delivered to children with cancer through the development and implementation of workforce training packages, as Liliana has exemplified, and the development and implementation of national and treatment guidelines that has been achieved in countries like Peru, Ghana, and Jordan. Also, at regional level, another excellent example of the progress achieved through the Global Initiative for Childhood Cancer is the Eastern Mediterranean Global Initiative for Childhood Cancer Call for Proposals, which provided a regional governance structure to define and accomplish shared outputs of advancing the childhood cancer agenda in the region. This strategy led to the prioritization of childhood cancer into national programs and policies in countries like Iran and Palestine. Also, the Eastern Mediterranean Regional Office has been supported in guaranteeing access to essential cancer medicines for children with cancer in vulnerable settings like Libya, Syria, and Lebanon, providing support for the procurement and purchase of these essential medicines. As I mentioned before, monitoring the implementation of cancer programs with a specific focus on quality and coverage is fundamental to strengthening health systems at national and local levels toward improving access to cancer care, particularly as we're talking today about the importance of early diagnosis programs. Recently, the Non-Communicable Disease Monitoring, Surveillance, and Reporting Unit at WHO headquarters has developed a primary care facility-based patient and program monitoring framework and indicators, which incorporate for the first time childhood cancer indicators that are aiming to evaluate the capacity and efficiency of early diagnosis programs for childhood cancer, as well as the national referral systems. Some indicators that have been proposed are core indicators that evaluate the capacity of the workforce for evaluation of the early diagnosis of childhood cancer signs and symptoms that Liliana and Dr. Eddy have shared with us. So these will be monitored through this proposed framework. Also, indicators that evaluate the timeliness of referral once a child for the first time enters in contact with the health system until the child reaches the specialized center where treatment, diagnosis and treatment will be provided. So these are important indicators to measure the capacity and performance of the health systems. And more recently, we are working together, as mentioned before, in the process of developing the global monitoring and evaluation framework for the Global Initiative for Childhood Cancer, which will contribute to evaluate the performance of the different childhood cancer programs at national and regional level. The methodology for this monitoring and evaluation framework builds for the already approved NCD facility-based patient and program monitoring. Now we are working in proposing a set of core and aspirational indicators metadata for childhood cancer, which will be assessed through an expert informal consultation with the participation of the experts that are part of the GICC working groups and networks to guarantee the adherence to geographical and gender equity. The initial indicator metadata draft will be submitted through a process of Delphi expert review to determine the relevance, validity, feasibility, actionability, and alignment of the proposed menu of indicators. Here's just a quick snapshot of what this framework looks like. It's still in the process of reviewing, as we mentioned, but this will help us to evaluate the performance, the gaps, and the needs for improvement in the countries that are actively engaging in the Global Initiative for Childhood Cancer. So now to conclude, I will give the floor to my esteemed colleague, Dr. Andre Ilbawi, to finalize our presentation. Over to you, Andre.
Thank you so much, Roberta. I really thank you for your leadership of GICC. Thank you to dear Saghir, Dr. Saghir, Kathy Pritchard-Jones, Mychelle, and the team for hosting this important event, and to each of you, many dear colleagues and friends, for joining the meeting today and joining in this important movement. I would like to begin with some brief comments to congratulate each of you for your passion and for the coordination that exists in our community. You are now speaking with one voice, and we are stronger because of it. Thank you also for being so collaborative with WHO, for welcoming us into your community, and for your support of GICC. Just to think, more than 60 countries engaged in GICC. This is a tremendous success because of you, because of us, and our collective voice. The prioritization of childhood cancer is and will continue to have a direct impact on the earlier detection and addressing barriers to care. Perhaps given the time, I will briefly share two reference studies. First, to emphasize the power of advocacy, as Liliana has shared. In Thailand, By simply including a cancer in their benefit package, they were able to downstage disease. The principle here is that early diagnosis cannot happen if families have to pick between their financial health and physical health. In a second study, in a hospital in South Africa, they placed a title that just said breast cancer clinic on the building. That simple action resulted in the downstaging of disease. If people know they can access care, they will come. We are changing this narrative together. We are in fact promoting childhood cancer as part of UHC, helping cancer centers and hospitals build capacities, and we're doing this together. Now with each meeting, with each act of passion and advocacy, we are making a difference together. Thank you to each of you for being agents of change and for your tireless passion for the well-being of children with cancer around the world. Thank you.
Thank you so much, Dr. Ilbawi and Dr. Ortiz. It's really wonderful to hear your presentation, knowing that we see that it's not enough to work with the country level at the Ministry of Health, but to work with the healthcare teams to really transform what is happening at the local level with the local hospitals, creating opportunities to raise awareness and to expand their opportunity to reach out to the communities and the people in need. There have been a number of questions in the Q&A box, and I'm hoping that the presenters will help to answer some of these questions, maybe elaborate a bit more. We only have a few minutes for this type of discussion, but there were questions around what can the pediatricians do to help to reduce delay in that referral period. Are there any specific recommendations when someone suspects a cancer around testing? And the other issue is around preventing relapse. If we, as pediatricians, may be able to do something in our practice with our patients following their cancer treatment to recognize relapse early and help to promote earlier interventions for the relapse patients as well. So I'll open the floor to the panelists for the response. Anyone could answer.
Maybe, hi, as Kathy, SIOP president, I'd like to take the question of early, a blood test in the community. I think that is not such a far-fetched idea that, in adult cancers in America, they have a cancer blood test. You can look at methylated tumor DNA in the circulation, and it's been offered as a diagnostic test to triage somebody's risk. This is not yet available or even tested in children, but I think the concept of having some circulating tumor DNA detection on a blood test in the future is not impossible, but it's probably a decade away. But children's cancers present in specific ways. The white eye symbol for retinoblastoma is something that you need to train community healthcare workers and parents to recognize and know what to do about it. Early examination, careful examination of the abdomen to detect a solid tumor mass. All these things, I think, can be more simple. I see Andre has his hand up and Roberta, so I'll hand over to my WHO colleagues.
Great, thank you.
Please go ahead, Roberta.
Thank you, Andre. I just wanted to share that it's a very important question because I do think that general practitioners, pediatricians, as well as general practitioners at primary healthcare level play a very significant role. As we have mentioned, when we have the workforce that is already trained to be able to identify and following specific standardized referral pathways, I think that this is significant to promote in countries, because sometimes we have seen like the experience, and I can speak for myself in Latin America as a pediatric oncologist in Nicaragua. We developed a program for early detection of childhood cancer, working very closely with peripheral clinics and general pediatricians in district level. So having the specific system for referral and knowing that there's somebody who is responsible to be the contact, the focal point to contact a specialized center is vital. So institutionalizing this sort of practice, having first the workforce train with the capacities. Here we have now available the PAHO modules for early diagnosis. And we also have the written document that's a little bit outdated from the WHO following the integration of approaches for integrative diagnosis of childhood cancer from PAHO as well. That all these tools can be at hand to train the pediatricians and the first line practitioners at the first contact point in the peripheral clinic. So I think that this is very valuable, and as we have mentioned, through the implementation of the monitoring and evaluation framework, trying to evaluate where the gaps are, how many health workers have been trained in early diagnosis courses. This will be very vital to start understanding what we need, where there's need for improvement. Over to you, Andre and Liliana.
Thanks, Roberta. Just the 2 points, and Kathy and Roberta have mentioned really the most important parameters. 2 other interventions that we've seen have value is a lot of the discussions we've had today, and a lot of our efforts are on in-service training. That is training of people who are already in a professional role. But it is absolutely critical to change the medical education curriculum so that nurses, physicians, community health workers in their training also become agents of change. We have some good data in adult cancers in a country like Rwanda that even 1 or 2 graduating classes can have a transformative impact on the knowledge of cancer and the importance of early cancer diagnosis. The second is going back to the important point that Dr. Agus writes to Dr. Eddy, and maybe Dr. Eddy can speak to this. Most primary care providers have a reference for what types of conditions need or what types of symptoms require referral and to whom. Now, it isn't standardized in many countries, but the principle is. So it would be important as part of our policy dialogue that we engage with the question of what are the referral triggers, and do the providers know where to refer when those conditions arise? And that's another policy intervention that may be appropriate depending on the system. Thanks.
Great, thank you so much. I think there's also a question in the Q&A box for Dr. Eddy, asking about the issue of requesting more information about patient delays for referrals in low and middle income countries. I think maybe actually Andre and Roberta may want to add on to this as well, because they do. The question relates to how governments are mapping this issue and strategies for advocacy at the government level, at the national level. So Dr. Eddy, if you could start by maybe a little bit of elaboration, but I think our colleagues from the World Health Organization might also want to give some comments on how governments play a role in reducing these delays. Dr. Eddy first.
Thank you very much, Dr. Mychelle. I do agree with the statement of Andre Ilbawi that we have to train a primary healthcare provider instead of a medical doctor or general practitioners, because in some low middle income countries, the general practitioner has a rotation in their situation. But the people who always stay there is the nurses and the midwife. So this is the key point to make a change, agent of change. And then for the referral system, we have the experience for the children who have suspected to the malignancy, so they can jump from the primary healthcare due to the system to the tertiary healthcare. So they can pass by the secondary healthcare. This is the shortening the length.
Great.
That's my answer. Yes.
Thank you so much. Dr. Liliana, would you want to add some additional comments here too?
Thank you so much, Mychelle. Yes, I wanted to add something about the question of the referral that also links to this question as well, because that is something that it's very important for healthcare providers. Once you have the suspicion of cancer, what do you do? If you know that the referral pathways are very complicated and it's difficult to refer the patient, and this is something that, for example, as our experience in Latin America, and particularly in Peru, we focused a lot on building two things. One was, as Roberta was mentioning, also to increase the possibility to have these regulations, these normatives, not only at a national level, but perhaps at institutional level. You could always have this standards or guidelines to how to refer a patient with a suspected cancer. And this is something that also links to a question in the chat about this IMSI strategy of early detection of childhood cancer. We have a manual from PAHO WHO that has this strategy on how urgent is the referral of a child with suspected cancer, or not urgent, or perhaps it could wait a week or 2 weeks. So this is something that it's different from every situation. Of course, not every situation is so urgent, but it's important that all care providers can have this information, and that, again, we have to learn more about this for training ourselves. And this is why also to follow this CEDAR series is important, because in each of the session you will follow on retinoblastoma or suspected leukemia or brain tumors, and that is why every situation could be different. And another thing that I wanted also to mention is that, for example, an experience that we had in Peru, and that is also being extended to other countries, is that we use some telemedicine tools, such as the application named Oncopeds, that it's very simple. It's actually a link to communicate from primary care physicians to specialists, pediatric oncologists. So this is something that is very replicable in many other countries as well. And it's a way that we can, as healthcare providers, also use this technology to decrease the time to diagnosis of these children. Thank you.
Great, thank you so much. Are there any other comments from the panelists? We might give you one minute for any additional comments before we go to summarizing.
I think Dr. Ante raised very important point about adding this education about the childhood cancer in curriculum. So probably International Society of Pediatric, International Pediatric Association and National Pediatric Associations can do something to push the policymakers to add something similar in the, at least at the medical school levels, or add some sort of courses or the workshop, something similar to improve. And the other thing which I would suggest in the question and answer, we see certain questions about Burkitt's or ALL. So we have all these topics in the next webinar sessions. So I would encourage the participants to stay tuned and participate in the next sessions as well. Thank you.
Thank you so much, Saghir. Yes, this is a wonderful time to, I think, turn over to Dr. Claudia, but I also want to, from my side, thank all of the panelists and all of the participants for the questions, having a great time to discuss. Together, we will become the agents of change that we need for childhood cancer. And it's an honor to see SIOP working together with the International Pediatric Association. It shows the collaboration can have an impact. So for all who are here, we hope you will participate in future webinars. Thank you again, and I'll turn it over to Dr. Claudia.
Thank you very much, Mychelle. So after these interesting moments of knowledge exchange and interactive discussion, this exciting webinar is coming to an end. We are really grateful to the highly esteemed speakers of these sessions. Thanks so much to all the audience for joining us in this educational activity. We are really look forward to seeing you all in the upcoming webinars, focusing on the 6 WHO index cancers, It's indeed a pleasure for SIOP Education and Training Committee to actively collaborate with the International Pediatric Association, led by Dr. Aman and Dr. Mychelle. Working together as a team, we can definitely meet our goals and objectives. We highlight, acknowledge, and appreciate the support and effort of the SIOP office team and the kind assistance of the IPA admin office to successfully conduct this webinar. Many thanks again, and see you all on 14th October in the second CEDAR webinar about acute leukemia, acute lymphoblastic leukemia.